This week on the BackTable Podcast.
Yeah, so the rate of infertility in urologists versus the general population is actually quite a bit higher than our age-matched peers. Only about 1% of the national population conceives via assisted reproductive technology or techniques versus 10.6% of women urologists have reported needing some sort of assisted reproductive techniques to conceive. Pregnancy complications are higher as well in women urologists, with about 25% of female urologists, when surveyed, said they had some sort of pregnancy complication. This is significantly higher than the general population.
Hello, everyone, and welcome back to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor.
Fellow provides mail-in semen analysis for clinics looking for improved compliance and a patient-friendly solution to vasectomy and fertility testing. Their CLIA certified lab combines the ease of a mail-in semen analysis with peer-reviewed clinical performance to provide reliable results in less than 2 business days. Fellows testing dramatically improves the experience for patients and clinic staff, achieving compliance rates of up to 95% compared to published rates of 30 to 50%. Here's a couple data points. Urology of St. Louis has tested over 3,000 patients with Fellow, and their compliance rate increased by 62%. And the VA Boston saw a 119% increase in compliance for post-vasectomy testing with Fellow. To learn more about Fellow's vasectomy and fertility testing, visit meetfellow.com. That's MEETFELLOW.com.
Now, back to the show. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today. We have Charla Holdren, who's a resident at University of Michigan West, and Christine Van Horn, who's an endourology fellow in Chicago, affiliated with the Loyola program. Charla, Christine, how are you all doing today?
Doing well. Thank you so much for having us on.
Yeah, doing well.
All right. So I feel like this is a really important topic that's nearly certainly underappreciated, underdiscussed, and just starting to garner the attention that it does. And it really has to do with fertility, family planning, considerations for female surgeons really across the spectrum. And, before I jump into it, I did want to just share a personal story. My sister is a med-peds provider and hard worker, like I think most people going into medicine are. She's also a type 1 diabetic. And, 4 years of residency flew by and finally started having some of the dust settle, thinking about having a family. And suffice it to say that it was challenging, and the, let's just call it, typical routes of family planning weren't available to her and my brother-in-law. And, it was tough for them. It was tough for the family. And, I guess I experienced that, but I never really thought about what the prevalence of these types of things are. How is it impacting females kind of across the healthcare spectrum, surgeons, urologists specifically? And maybe we could just start out by having each of you just talk a little bit about, what drove your interest and passion towards this critically important topic. Charlie, maybe you want to take it away?
Yeah, so I think fertility preservation for me was something I was interested in early. I went to med school later in life. I had a different career previously. I was in education and I was a paramedic, and I had a wonderful time prior to medical school. But then, coming in late, going into residency late, I was hyper aware that females' fertility declines in their late 20s or early 30s, and I was coming in, I started when I was 30. So I knew right away I wanted to make an appointment with reproductive endocrinologist and get that, at least the informational appointment started. So I knew early that was something I was interested in, and I ended up going through the whole process and going through cryopreservation of both oocytes and embryos during my training. So it's a long process, and it's a very difficult process and very expensive, but something I'm happy to share more about. And I'm pretty passionate about encouraging other women who are thinking about it or have questions to explore more.
Thanks for sharing that, Charla. Christine, can you tell us a little bit about what drove your interest in this subject area?
Yeah, so I have a similar background to Charla in that I am a non-traditional person to the medical career. I had a life in basic science before I went to medical school. So I came in about 5 years after graduating from undergrad. So I started residency at around 32. And I started thinking about it midway through residency when I realized, I was very busy with my career and eventually I'd want to have kids, but realistically it wasn't going to happen for some time. And I thought about preserving my eggs when I was a resident. I ultimately chose not to, but it was a very difficult decision. It was a very long process looking into my ovarian reserve, more so than I realized. And I got involved in some work as a resident with my program director, Jen Yates, over at UMass, looking at just the way we deal with people having children in training, whether or not there's still stigma, do people feel comfortable, how is it handled, and thinking about just how little we talked about it, sort of the physician heal thyself aspect of how we needed to talk more about it. And my experience with colleagues whose partners had children and they took time off, and sort of seeing how we dealt with that as a department and how that was different than it would have been decades ago, just has really kept my passion up for making sure that we tackle this as a specialty.
Again, thank you for sharing that. And I'm not sure how much of this was me or the culture or the environment. And I'll be the first to acknowledge that I think this is, of course, front and center for people like yourselves, Charla and Christine, that are having to have these super difficult conversations, go through the thought process. But I will share that I literally almost missed the birth of my second child because I thought it would be inappropriate to request time off around a period of uncertainty. And, thankfully the chips fell like they would. And I'd like to think that, regardless of what anybody thought, myself included, I would have left and, been there for that life event. And I get the sense that things are better, but nearly certain there's room for improvement. Well, let's jump into it. Maybe we can talk a little bit broadly about women physicians compared and contrasted to the general population, average age of having children, involving a fertility specialist. Can you give me some ballpark statistics of, how prevalent these types of things are?
Yeah. So just starting off, when you think about the average person having children and being a parent, for urologists, they start about 6 to 8 years after their peers in other fields based on CDC data. So this is people who are often in their mid-30s when they start having children, for folks like Charla and me that potentially maybe even later, often after they complete training. And across all subspecialties within surgery, women tend to have fewer children. So they'll have about 1.4 biological children on average compared to about 2.6 for the average person in the U.S. And female surgeons have fewer children than their male counterparts within surgery as well.
So having children later, having fewer children. And what about having to involve specialists as a part of their family planning?
Yeah, so the rate of infertility in urologists versus the general population is actually quite a bit higher than our age-matched peers. Only about 1% of the national population conceives via assisted reproductive technology or techniques versus 10.6% of women urologists have reported needing some sort of assisted reproductive techniques to conceive. Pregnancy complications are higher as well in women urologists, with about 25% of female urologists, when surveyed, said they had some sort of pregnancy complication. This is significantly higher than the general population. And surgeons face pregnancy loss at a higher rate as well, with about twice the rate of the general population. So it's a huge issue that women in training and practicing urologists face when trying to build a family and when choosing when is the appropriate time. Like you said, things are getting better in terms of not feeling guilty taking time off to build your own family, but there's still that pressure definitely of feeling like you're taking something away from your program and your colleagues when you're trying to figure out when is the appropriate time to do this.
Yeah, I appreciate you sharing that. And some of the numbers that I kind of ran across in preparing for this podcast, the American Association of Women in Medicine suggested about 1 in 8 of the general population interface with a fertility expert during the process of family planning, and that's closer to 1 in 4 among all female physicians, which is obviously double. And in addition to the time, there's going to be costs and so forth that kind of come along with that. So pregnancy-related complications, that sounds like an obvious risk of delaying pregnancy that urologists face. Are there any other risks that you're aware of that may just not occur to somebody who hasn't spent a lot of time thinking about this?
So I think one of the biggest things is just thinking about what advanced maternal age or advanced paternal age actually means in terms of the impact on family planning. So when we talk about women over age 35, which is the cutoff for advanced maternal age in the literature, it's associated with a mild reduction in fertilization rates when you look at the total numbers. But more importantly, it's associated with reduced ovarian reserve, reduced ovarian competence for fertilization, and an increased risk of aneuploidy. And there are a number of mechanisms that underlie this, including mitochondrial dysfunction, telomere shortening, increased errors during meiosis as oocytes age, and other factors. But paternal age is also an important thing to consider too, which most recent literature cuts off at about age 40 to 45. I feel like that's something that we don't often think about, but when you think about it, physicians often get married to other physicians. Oftentimes they meet them in the hospital where they work. And as men age, there can also be issues such as an increased risk of genetic syndromes like Noonan syndrome, increased risk of achondroplasia, Down syndrome, congenital heart defects, and disorders such as schizophrenia and autism. And it's through very similar mechanisms, such as issues with frequent divisions through spermatogenesis and breakdown of the genome.
Yeah, so it sounds like it's really kind of, there's parent-specific issues that may arise, there's child-specific issues that may arise. You know, of course, we'll also talk about other options, adoption, surrogacy, delayed reproduction with using biological processes. Now, this might seem self-evident, but let's just talk a little bit about the work environment, the schedule, and how that seems to me like the backdrop for this whole conversation that we're having. Hours, stress, is this really what's kind of driving general delaying of this process, certainly beyond what our peers are doing?
I think that our work environment certainly has a lot to do with it. I know that there have been some studies showing that when you're looking at residents that do more than 6 nights of call per month, which is really not that much when you think about your residency training, they had higher rates of pregnancy complications than those with less than 6 nights of call. Residents had higher rates of miscarriage, hypertension, placental abruption, and growth restrictions compared to their age-matched peers who were not in medicine, so people obviously not taking overnight call. So part of that study was, they're thinking the thoughts might be due to the longer hours that these residents are working, your increased stress levels, and poor diets. Think about what you're eating when you're on call. So all those things, I think. But then if you think about just our job in general, we're on our feet, we're in the operating room where we're exposed to radiation. It is just quite a bit different compared to, my friends that I went to college with, a lot of them work at an insurance company or at a bank or things like that, where it's just very different day-to-day reality.
And I think too, the early starts to the day make it very challenging. If you're trying to get an appointment with a fertility clinic to even get your serial labs done for your blood draws after you do your hormone injections, or in my case, trying to get my ovarian reserve testing and having to go between one site in our city that was like a 10-minute drive away versus having to drive out to Waltham, which from Worcester, where my residency was, that was a good 45 to an hour, depending on traffic. Those are big constraints that are hard to do when you've got a 7:30 start to get back for.
I remember when I said that I was interested in doing this right away when I started residency. And when I first moved here, I made the earliest appointment I could with the fertility center here in town, which was at a off-site location. My hospital doesn't offer it. And the earliest appointment they could get was like 6 months out. And of course, I wait for that day. And then the day comes and we add on a cystectomy. that afternoon. So I have to cancel the appointment. And so then, the next appointment they can get is like 5 or 6 months later. So kind of in that same vein, we're at the mercy of our schedule, and it's just the reality of what we do.
I mean, I will say my faculty were supportive if I wanted to pursue the route. I think part of it was just the logistics and the time and just the guilt of feeling like I was leaving the team hanging as the senior resident, the PGY4 with the PGY5s, going off to do this very personal thing that just benefited me, my future children and future partner. But it felt different than, when I'm working long hours and it's like for the benefit of the patient, for the benefit of the team, for the benefit of the house of urology.
Thanks for painting that picture. Night duties, shifts, early mornings, sleep deprivation. I'm not an expert at this at all whatsoever, but I imagine that can impact menstrual cycles, overall reproductive health, tack on radiation exposure, which there's plenty of. These are all things that nearly certainly have an impact, I would imagine. But even beyond that, just like you're busy, you're reading, you're doing this, you're long hours, you're home, you're exhausted, like even the thought, like, let me start thinking about this. Charlotte, it sounds like that was something that was part of your life planning even prior to residency. But I would imagine that, there's plenty of women coming in and, obviously there's more women coming in, which is great for our field, that whatever their relationship status may be, they're starting a residency, they're busy, that's the focus. And maybe finding a partner, family planning, any of that isn't even just like anywhere near your radar. Is that true?
I would say in my experience, it kind of was. I came in, a little bit older. I came in single, and I was very much focused on getting to enjoy the specialty I'd matched into because this felt like, and it still is my dream career. And it was very different than what I had done before medicine. And so for a good chunk of time, like dating was a thing that was on my radar, but I wasn't focusing on it because I wanted to make sure to get the most I could out of my training. And it became kind of hard to have to acknowledge, the realities of time, and I feel like, it's a lot easier to just keep focusing on urology and all the great things that I'm doing and the projects I'm on and the cases I did versus like a little voice in the back of my head that's like, you're not getting any younger. Not saying you have to do anything about it now, but just think about it. It's very hard, especially when there's a lot of other competing factors for your attention and time, and you don't want to do anything that's going to derail your career, end up having it take away from something else that you value.
Absolutely. And I mean, it sounds like peak career needs and peak biological timing are like essentially overlaid in some form or fashion, at least in, contemporary 21st century society. So were there actually policies on family planning? I mean, maternity leave isn't exactly what we're even talking about yet, but just family planning, and you both are still going through your training, it sounds like, but as you're thinking about jobs and so forth, can you comment a little bit about, how front and center this was anybody else having children, whether those were males or females, and, what did that look like?
I know for me, I'm at a small program. I was the first woman to come through in decades. And so there really hadn't been the question of maternity leave in quite a while. And I met my now fiance 3 months before I started intern year. So I wasn't really thinking that would be in my future either. But of the men that have had, their partners have had kids during the program, it's similar to what you were saying where, it's like, well, can I take the afternoon off? My wife is giving birth, that kind of thing. So while I feel my program is incredibly supportive towards growing a family and being there for your family, having the established maternity, paternity policies is something that I think every program probably could do better with publicizing to the people that are interviewing there so that it's not, you don't feel like you're going out on a limb asking for that information while you're interviewing, because I remember feeling like that as a female applicant put me at a disadvantage, feeling like people would see me as a liability if I asked about maternity leave policies. Obviously, that wasn't the position I was in at the time, but just something I have thought about since then and have tried to convey to people coming up as students now, that they should feel safe asking for that information.
Yeah, absolutely. I mean, I can imagine that sharing that's kind of a part of your 5-year or 6-year plan would be uncomfortable for a person who's entertaining joining any residency and of course being evaluated by that residency. And I don't know, it's just, this is the type of thing that hasn't really jumped in my head before, but it seems like it's super obvious that, hey, I'm going to need some time off potentially because I've got these life goals. You know, Christine, when you were talking a little bit about the guilt, the house of urology, your team, the patients, it seems like you got work, there's stress, there's hours. Our field is getting notoriously known for burnout. And now you're adding on what I would consider should generally be a very joyful and positive part of our life journey. And it sounds like it actually adds to all of that. Did it feel that way for either of you all?
I think for me, it added on stress that I think was more self-imposed. I know historically, and there's some good data about the historical stigma that women faced choosing to have children in residency. Thankfully, that really didn't exist where I trained. I was one of only 2 women at that point when I was in training. We now have more women in our program, which is amazing. And so we never really had to deal with that issue. We had one male resident whose partner had a child, and we kind of used that as the benchmark for how we were going to treat everyone moving forward with having kids in terms of, not having him pay back call when he took time off to be with his child, supporting him going to doctor's appointments with his partner when she had ultrasounds and things like that. Basically, treating him the way we would want to be treated if we were in his shoes. And I think that was a really important thing that we established in our program, especially as a newer small program, that this was something we were going to value. I think it's just hard as a woman thinking about that because there's just so many variables that you can't predict. It's not like taking a vacation or, other plane time off like an elective surgery where when things are going to happen, you have a rough sense of how you're going to recover. I always worry when I get pregnant, am I going to be one of those people who has preeclampsia and then I have to be on bed rest? And then what am I going to do about my cases? What am I going to do about my panel, if I'm attending at that point? And I think that is self-imposed stress because so far, I think everyone I've met has been very supportive about people being people and building families. But, it's hard to take that step back and say, you're allowed to be a person too.
Yeah. And I actually was absolutely alluding to self-induced stress. 99% of any stress that I have is because I don't say no or other ridiculous decisions. But I am glad to hear that, you felt from from your co-residents and your peers and your attendings and the institution, it sounds like to be supported. Curious, maternity and paternity leave policies at your respective institutions, do they exist? What do they kind of look like?
We didn't really have policies for that. I think people generally used their sick leave for planned maternity leave. And then if they had vacation, they would use the vacation. A lot of my female colleagues in other surgical subspecialties would just take all their PTO and then get into short-term disability if they needed to. And there's data to support that trainees generally take a lot less time off after delivering. I think partly just due to the realities of what you're allowed to take off in your contract.
How do you feel about that?
Not great.
Is that a good policy? Is it medium policy? Is it a bad policy?
I would say it has room for improvement. I'll put it that way, because I don't think it's out of any sort of, ill intention. I think it's just, you don't know who's going to get pregnant. You don't know what that's going to, mean. And, I don't think anybody was trying to shortchange female trainees because you also have requirements of your specialty boards in terms of how much time you're in. And you don't necessarily want to delay graduation because that impacts fellowship. Are you going to be this awkward off-cycle person who, finished in November because of maternity leave? And then which cycle do you apply to for fellowship? There's stuff like that where it kind of gets more complicated. So I think sometimes people just want to be able to take just their PTO and get back to work and not have it delay things. I think there's definitely room to improve and make it a little bit easier for people to take more time off if they need to. But it's even with breastfeeding. I had a friend from undergrad she was ped psych, and she was talking about how the AAP recommendations about breastfeeding are really, really hard to achieve as a physician just because of the time and the logistics it takes to do it. And she was honestly shocked how long or how difficult it was to maintain breastfeeding when she went back to practice. So I think it's something that across the House of Medicine is, it's very challenging to figure out good policies that support people and, give them enough time without too much or not enough.
I will say, if anybody listening has an interest in this, the Society of Women in Urology is putting together resources for, breastfeeding resources, for maternity leave resources across institutions. And hopefully we'll have some good documents that people can look at, some fact sheets, things like that, so that when you have to cross this bridge and you need to approach your department chair, your program director, things like that, you have the data that shows what other institutions do, and you're not just walking in empty-handed. So I think with more women going into the field, we'll develop policies that work for everybody. At my institution, like I said, I haven't had to do the maternity leave thing at this point, but I remember talking about it and being very stressed out about it. Like we said, a lot of the stress we go through, we put on ourselves. And my chief, who's a very wise and compassionate guy, was like, so what? What if somebody breaks their leg and can't come to work? Things happen to people, and we make it work. So I do think that people are humans and you figure it out. So luckily, I'm at a good place.
I couldn't agree more. I mean, when I was attending, we had a family situation, and I called my chair. I said, I have to leave instantly, immediately. I'm not sure when I'm coming back. And you know what? The world turned, and my whole team was super supportive, and it was a very touching experience. It was a very humbling experience that, again, the world will revolve without us squarely in the center of it. Well, that's nice to hear about support systems and resources that are kind of coming through. I think it's actually really nice here at UC San Diego. This was a relatively newer policy, and our general reimbursement system is a production-based system that for women breastfeeding, there's actually RVU compensation built in for so many sessions per day. And, again, I think it's kind of forward thinking on the one hand, but in reflecting on it a bit, gosh, it seems a little bit odd that it's 2024 before something like that kind of came through the pipes. So both of you all have been through some process utilizing advanced reproductive technology. Can you talk a little bit about the time and the costs associated with that?
I can start with just the basic, the first thing you do is you get your consult with a reproductive endocrinologist. I did mine over telehealth, which was great because I could meet with him at any time, day or night. And I think I did a late evening call with him after work was done, on a clinic day. And then there's the establishment of ovarian reserve. So that's some blood tests and then an ultrasound to assess follicle count, which was a little bit challenging because depending on what birth control you use and how your period is, timing to get to the right day of the cycle can be a little bit of a challenge. So it actually took me 6 months to get to a point where I was at the right point in my cycle. It was a reasonable time to actually leave the hospital and drive out to Waltham and get all my stuff done on a Saturday when it was doable. But that part ended up, thanks to the way healthcare is in Massachusetts, a lot of it was covered by my insurance for the beginning part of it. So I was only out, I think, a few $100s, or may have just been just $100 to cover what wasn't covered by my insurance for labs for the workup. That part timing was challenging, but cost and feasibility was pretty reasonable.
Thanks for sharing that. Charla, anything from your end?
Yeah, so then after that, if you decide to go forward with cryopreservation, which you can choose to do either gametes or embryos. So embryos are hardier. They're more likely to survive the freeze and the thaw. But that means, of course, that you have to have a partner who's ready to freeze embryos with you. Or you could do a sperm donor, I guess, if you wanted to go that route. But if you're just doing it on your own, most women choose to just do the oocytes. So for the cryopreservation, you have to go through chemical stimulation. So you have to pay for the medications. And at my institution, our insurance didn't cover any of this. And it was all at an outside center. None of it was at my hospital. So I had to drive to an outside center. I had to pay for all of this out of pocket, which, goes into the thousands of dollars. If you want to go through the full IVF, where they're not just harvesting and fertilizing, but they're also re-implanting, it's the tens of thousands of dollars. So you are, injecting these medications every night. You're getting blood draws every other day to monitor serum hormone levels. You're getting pelvic ultrasounds. I was getting them every other day as well. And then they're calling you every afternoon to tell you, your hormones are this, you have your ultrasound showed this, so we want you to change your medications. And then when you have your follicles or they have enough that are over a certain size, they schedule the harvest. So unfortunately, you don't know when that's coming until about 2 days before. So it's not like you can schedule PTO. So that was also a very challenging aspect of it, is you just have to hopefully have a team that can be flexible around that. And then the procedure itself was pretty quick. I think it only took about an hour or less than an hour, but you were under MAC anesthesia. And so you needed a driver, which, like most of us, I'm in a city far away from my family and all my friends are residents, so they couldn't come drive me. So that was fun. I had to get somebody that was post-call. Yeah.
I'm sorry. The thought of having a post-call resident pick you up, it just, man.
Yeah.
How bad was call that night for them?
Yeah. Oh my gosh. You're just like super bloated and you're hormonal. And my poor co-residents dealt with me that whole week, and they're saints. But it's physically uncomfortable. It's emotionally taxing. It's financially taxing. And then there's like the next week afterwards where they're giving you these phone calls to update you how many of the eggs survived, how many of the embryos survived, and then up to day 5 when they finally get there, I think it was 5 days, how many went into like the deep freeze, and you get kind of attached. So I remember being between cases and getting the call that like half the embryos had not survived, and I just broke down in the locker room. And granted, it was probably all the hormones, but it's a pretty tough thing to go through when you're not, telling people what you're going through. But I'm very glad I did it.
Yeah, I mean, I can't imagine. I think what I'm hearing is it's certainly at the very bare minimum a multi-week, more likely multi-month process with significant physical and psychological impact. And then you're trying to navigate that with a lot of uncertainty kind of peppered in. I mean, it almost sounds like certainly during or around the time of harvesting, and it sounds like if you're going to go the implantation route, that just layers in a whole nother element of time, money, and complexity that, a couple weeks off just to get that handle wouldn't be the worst thing.
Yeah. So with us, my fiance doesn't live in state. So there's a whole nother process added to get his semen analysis. And then we had to freeze the sperm in order to do the fertilization because he wasn't going to be here when we had the harvest. But yes, if you're ready to get pregnant at the time, doing the implantation, once you've already gone through all that, they just bring you back in and you just keep going with that cycle.
Yeah, I mean, it sounds like a lot on top of just kind of the general demands of residency.
Yeah, women who go through IVF are some tough ladies.
Yeah, I mean, the success is very much outside of your control. Like the age you choose to harvest your eggs is important in terms of the yield and the quality of the eggs. But beyond that, it's whatever your body wants to do. And we know bodies don't read the textbooks. So, having to take that perfectionist surgeon who wants to have control of everything, control every variable in the OR, optimize outcomes, and have to take a step back and be the person, like the patient who's on the table who has no control over anything. It's very stressful to think about. I thought a lot about what if I did this and it doesn't work? What if I do this and then the eggs don't even work? What do I do if I end up not eating the eggs? It's just, like we've already said, it's so much uncertainty, so many variables you can't control for.
Yeah, absolutely. Maybe I'll ask for you all to comment and reflect a little bit on the current state as it pertains to resources, support system, and what you envision kind of a better future state, including what type of policy changes, recommendations, institutional, professional society support are going to be required to get us to this better state.
I mean, I think the first thing is just the culture shift that's already started. I mean, thinking about the changes with the ABU board rules in terms of the way you could take your time off to allow for people to use their time off for pregnancy. I think that's a huge, move in the right direction. And we've done some internal work where I did residency to kind of see, sort of take the temperature of how things are. And, I think in addition to other studies that are out there, overall, like the vibe is becoming people want to have a life outside of medicine. They want it to be in a rich, fulfilling life outside of medicine, in addition to having a rich, fulfilling life within medicine. And so I think just having that as the soil upon which everything grows is so hugely important, because it doesn't matter what policies you have. It doesn't matter what rules you have. If no one really believes that following the rules or allowing others to use the rule as it's intended, if they don't believe in that, it's not going to matter that the rule exists. Like if you get, 8 weeks of maternity leave, but then your department pressures you on the inside to not take it, like it's not going to matter that you had that time. So I think we're kind of globally making the, some steps in the right direction. And I think that's like really the foundation, is just, allowing for that. And I think too, allowing for paternity leave. I think historically, the stereotypical surgeon is, the guy who works 100 hours a week, never sees his kids, isn't there for their deliveries. And he's like proud of the fact that he's working so hard that he's not there. And, one of my male co-residents wanted to be there every step of the way with his partner. And he is an amazing dad. And I'm so glad that he's there sort of showing how things have changed within our specialty and just within the house of medicine. So I think that part, is super important too.
It's interesting that as urologists, we are or should be so comfortable speaking to men about cryopreservation and fertility preservation when they have testicular cancer, but we're not comfortable, talking about it amongst ourselves. And maybe it's that stress we put on ourselves that it's selfish, and you can't be taking time away from your training and your patients to focus on your future. But it's just a shifting mindset. I think something else with this going forward, being interested in, infertility and andrology with the current political climate and things changing with IVF. And it's definitely something that to keep an eye on. And, will there be restrictions on that in the future? And with me having eggs and embryos in a freezer somewhere, do I have to worry about what state they're in? Where I go practice, do I have to worry about having them shipped somewhere that suddenly I'm not able to thaw them?
Yeah. And I think for urology, especially as I've gotten more involved in advocacy, like through the AUA Summit and through various parts of the PAC, thinking about the various issues that affect our specialty, the workforce is a huge one. And as more and more women come into the workforce, and as we have younger and younger urologists, filling in the ranks to, allow us to address the workforce shortage, there's a culture shift amongst young urologists. And I think too, like at the same time, we have urologists who come in that are a little bit older. Like some of the resident census data showed people coming in their early 30s for urology residency. And so these are people where this is going to be more and more salient, and sort of thinking about how we allow people to be people and then also practice medicine and keep them in the workforce, because a lot of data has come out about, just women in medicine in general, and that there's a variety of factors that play into it. But ultimately, about 40% leave full-time practice. They go to part-time work, or they leave medicine entirely within their first 6 years of practice. There's some sort of shift away from full-time work. And that is something that is important across medicine, but it is especially critical when thinking about urology, because we're already, at the straining point in terms of not having enough urologists to cover the needs of our patients as our patients age. With 62% of U.S. counties not having a urologist, and in some states that means there's practically no urology care, like this is a really important issue to think about.
Totally. And, that was obviously one of our front and center AUA Advocacy Summit policy issues on the workforce and the changing face of the workforce. Lindsay Harrell did a great job kind of sharing where we're at and where we're going. And I think at a very fundamental level that if we're kind of addressing this head on and making it part of the process, as opposed to something where you got to stop, pause, and possibly consider, really shifting your life trajectory, it's better to be proactive and understand than reactive, scratching our heads while things continue to exacerbate, I suppose. Well, I would love to kind of hear just some parting thoughts from either of you all if you feel compelled. Just thank you in advance for talking about this subject and your personal stories as well.
I think the most important thing is just there is no shame in talking about any of this, and finding, people within your department, people within your hospital, finding support to talk about this. I think this is so crucial. Like, it is important to remember that you are a urologist, but you are also a person. You're a human. You have a life outside of medicine. And however, if you don't ever have to deal with this issue, if you do, however you approach it, like, it's important to remember that that is an important part of your existence. And it's okay to prioritize yourself as much as we prioritize our patients. Because if we aren't there, because we're not taking, care of our general health, taking care of our lives outside of medicine, we're not going to be there for our patients. And that's ultimately going to be to their detriment.
Yeah, I agree. Thank you, Christine, for kind of summing it up. And thank you for having us on. And we're recording this during National Infertility Awareness Week. So I think this is a great time to talk about this. I appreciate you giving us this time.
Yeah, no, it's an honor to be on here. I feel like one of those long-time listener, first-time caller situations. So
exactly.
It's great to get to be a part of the BackTable legacy.
Yeah, I wish we had some stand-up comedy we could give, like the testicular cancer one.
Oh, they're all so good, but that one was very good.
Well, the honor's all mine. This is one of those things that I think male, female, non-binary, in a relationship, not in a relationship, younger, older, it really affects us, or it can be more than 1 or 2 degrees of separation away. But before you know somebody that's kind of contended with this front and center, I just recall another experience during residency. I was a chief resident when my wife got pregnant, and it was a Saturday, and one of my co-residents, we were in the research room together, and I told her, and she just broke down crying, and we kind of talked about it, and she just shared her experience going through IVF and just trying to arrange all of this, and it broke my heart. It really did. And, fast forward, 11 years later, they've got 2 beautiful kids and all that. But again, I think this really affects all of us. I think it's incumbent for all of us to really make sure that this is being addressed head on. And, congratulations to the work you all are doing, the Family Planning Task Force is doing, SWU is doing, and really making it that such topics are front and center. So thank you, Charla. Thank you, Christine. It was a pleasure having you on, and keep doing the good work.
Thank you.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles,
Josh Spencer. Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.